It's about less than 2 minutes, sir. I will announce when.
Did any of you guys have much chance? I suppose it was difficult to join the ACC. It's probably the wrong time of day and wrong days of the week.
Yes, we did have a chance to join ACC meeting.
Okay.
The different programs.
Well, it'll be interesting to see. I mean, I picked my selection of what I thought was interesting, but it might not be the same as yours. So again, maybe you'll have other things you want to discuss.
It's 1 minute to time.
I've stopped getting very excited, for example, by yet another trial looking at some combination or duration of antiplatelet therapy after PCI. So if you were looking forward to some discussion of that, I'm afraid I don't have any.
No, but we have gone through the slides which you're saying.
Oh, you've seen them. Okay.
So
okay.
I think all the topics looks of terrific interest for all of us.
30 seconds. 30 seconds.
Okay, so let us.
10 seconds. Five. Please start.
Dear doctors, good evening. I am Pradeep Patni, the CEO of Noveltis. A great pleasure for us here to welcome you today for ACC Konnect, which is organized by our Noveltis division, headed by Mr. Altaf. In these unusual new normal times, I trust everyone and their family and friends are healthy and safe. ACC Konnect is an endeavor from our side to ensure that we are able to, in our own small way, contribute towards continuous medical education and learning. A quick word about Noveltis doctors. Akums, our parent, is India's largest manufacturing setup, and 12% of all the pharmaceutical tabs, caps, injections, etc., which are sold in India, come from our stable. Noveltis currently operates in therapeutic areas of gynecology, pediatrics, ortho, dermatology, ENT, and of course, cardiology and diabetology. Quite a few brands of ours were first of their kind, and we take great pride in successfully launching innovative formulations, which helped us for 3 years in a row to become the fastest growing pharmaceutical company in India. Going forward, in cardiology, we would want to create initiatives that will make us more relevant, more visible in your clinical practice. And we look forward to your advice and suggestions that will help us make our products benefit more and more patients. Thank you so much, doctor. Have a wonderful evening.
Thank you, Mr. Pradeep Patni. I am Altaf Qazi here. I take utmost pride and privilege to welcome all esteemed faculty and delegates to this important ACC Konnect initiative. I'm indeed very thankful to Dr. Shumitra Kumar, Dr. M.S. Hiramat, and Dr. Mohan for so nicely summarizing day 1, 2, and 3 proceedings, respectively, from ACC through short videos, keeping in mind the busy schedule of cardiologists in India. This special wrap-up session is a culmination of those daily updates. And to do so, let me welcome Dr. M.S. Hiramat from Pune, who has graciously agreed to be a moderator of this ACC Konnect initiative. We all know Dr. Hiramat is an internationally recognized leader in the field of cardiology, holds an extensive record for training young cardiologists across the globe at his workplace, that is Ruby Hall, which is in Pune. He's been invited to all major cardiology meetups across the world. One of the exceptional qualities that puts him aside is that he gives state-of-the-art treatment facilities to his patients, and majority of the patients continue to live there happily without any complaints. To no one's surprise, he was elected as the president of All India Cardiology Society of India in the year 2017. This superior recognition in the field of cardiology has supported him in giving proper directions to people who are diagnosed with coronary artery disease in early stages and create STEMI guidelines in India. Let me welcome Dr. J.C. Mohan from New Delhi, who despite his very hectic schedule has agreed to join us today. Dr. J.C. Mohan, Professor J.C. Mohan is currently Chairman, Institute of Heart and Vascular Disorders, Jaipur Golden Hospital, New Delhi. He has been Director of Cardiac Sciences, Fortis Hospital, Shalimar Bagh from 2013 to 17. Before that, he was Chief of Cardiology at Jaipur Golden Hospital, Sundarlal Jain Hospital, Metro Heart Institutes, and at Saroj Hospitals and an Heart Institute from 2001 to 2003. He has been a professor of cardiology at GB Pant Hospital, University of Delhi, and MA Medical College. He has served as the president of echocardiography. I extend a very warm welcome to Dr. Soumitra Kumar from Kolkata for being here today in spite of his other commitments. Professor Soumitra Kumar has been a professor in HOD Department of Cardiology, Vivekananda Institute of Medical Sciences, Kolkata. He has been a chief coordinator for academic services in cardiology in Rabindranath Tagore International Institute of Cardiac Sciences, Kolkata. Professor Soumitra Kumar is a consultant cardiologist, Fortis Hospital, Kolkata, and he has been a fellow for Cardiological Society of India, American College of Cardiology, fellow of European Society of Cardiology, fellow of Society of Cardiac Angiography and Interventions, fellow Indian College of Physicians, fellow Indian College of Cardiology, fellow Indian Academy of Echocardiography. He has been, Dr. Soumitra Kumar has been a past honorary secretary, CSI for National as well as West Bengal branch. Professor Soumitra Kumar has been a past president for Indian Academy of Echocardiography, past president for West Bengal Academy of Echocardiography. I also extend a very warm welcome to Dr. John McMurray, who has joined us from Glasgow, UK. Now, may I now request Dr. M.S. Hiremat to take over from here and set the tone for this program.
Thank you, Altaf, and we're all excited to be here, and everybody is very keen on listening to John McMurray. So over to you, John McMurray, and you are going to tell us the important highlights of the American College of Cardiology scientific sessions of this year. Over to you, John.
Okay, sorry, excuse me. Thank you very much. So first of all, I'd like to say thank you again for inviting me to do this. I'm amazed at your thirst for knowledge that you're doing this late on a Friday night, your time. I'm also very pleased to hear in the short discussion we had before we started that COVID-19 situation is improving in India. I think all of us in the UK have been very concerned about India because, as you know, we have a very strong link and affection for India in this country. So I was very pleased to hear that things are improving. So I'm going to give a very personal overview of what I picked out as my highlights from the American College of Cardiology, and obviously we all differ. My interests, I'm sure, are different than many of yours, so I'm not saying these are the highlights, but these are my personal picks from all the different things that were presented there. I've focused on late-breaking clinical trials and clinical trial updates because I think that's what most people are interested in. So I'm going to start with a trial that we've been waiting for a very long time, and that is the RAFT AF trial. This was a Canadian-led trial looking at AF ablation in patients with heart failure, either HFrEF or HFpEF. And this was a very interesting study because the two treatment arms were really very different. So obviously, as the name suggests, one arm was an ablation-based strategy to control the heart rhythm, but the other arm, the comparison arm, was also a very aggressively treated group of patients that included in a substantial minority of individuals, sometimes AV nodal ablation with biventricular pacing. So this was a really stark comparison of two different approaches one might take to management of heart rhythm in patients with heart failure and atrial fibrillation. So these were the inclusion criteria. So as I mentioned, patients had to have heart failure, either HFrEF or HFpEF, and then they had to have a substantial burden of either paroxysmal or persistent atrial fibrillation, but generally not atrial fibrillation that had been persistent for time. And again, I'm going to give you a very, very abbreviated summary of each of these studies that I picked out, but here's the primary outcome, which was death or heart failure events. And as you can see here, although event-free survival looked to be somewhat better in the ablation strategy group, the hazard ratio was 0.71, as you can see. Unfortunately, 95% confidence intervals were wide, straddled 1, and as a result, the p-value was not quite statistically significant using conventional 0.05 cutoff. And here are the components of the primary endpoint and some secondary outcomes in a bit more detail. So this wasn't a very big trial. It took a very long time to recruit. And as you can see, the number of patients having the primary outcome was rather small. You can see that there was a trend for both components of the primary outcome, all-cause mortality and heart failure events, to be somewhat less frequent in the ablation group than in the control group. But again, neither of the components were statistically significant. There were some quality of life and functional capacity endpoints that were significant in favor of ablation, but this was not a double-blind trial, and that always makes these softer outcomes a bit more difficult to be confident about. So, for example, if a patient knows that they've received ablation, or if an investigator knows the patient has been ablated, that may bias the these softer endpoints. What I suppose is more robust and objective is change in biomarkers and left ventricular function. So here you see percent reduction in NT-proBNP and increase in left ventricular ejection fraction. And there was a difference in these two measures in the ablation group compared to the control group. But again, I find this just a little bit difficult to be certain about, once again, because as I said, some of the control group here were getting AV nodal ablation and pacing, and it's always difficult to know what effect that might have, whether that might have had a negative effect on natriuretic peptides and ejection fraction. So does the difference favoring ablation reflect improvement with ablation, or possibly the detrimental effects of the control group intervention? So sadly, not a trial that I think really has told us anything definitive. And unfortunately, I would say that we still remain a little bit uncertain about the role of ablation. All the trials seem to indicate that there may be a favorable effect, but all the trials have their limitations, their flaws, and in my own view, at the moment, still haven't given us an absolutely clear-cut answer, although I do accept that overall, the evidence generally suggests a favorable effect of ablation. sticking with atrial fibrillation, I thought one of the clinical trial updates that was presented was also interesting, and that was an update on the Fidelio DKD trial. This was, as you know, a very large study in patients with chronic kidney disease and diabetes, comparing a new mineralocorticoid receptor antagonist, finerenone, with placebo. Now, this is a so-called non-steroidal mineralocorticoid receptor antagonist. It's supposed to be less likely to cause hyperkalemia and renal dysfunction, maybe to be more cardiac specific. It did reduce the risk of the primary composite kidney endpoint and also reduced the risk of a secondary cardiovascular composite endpoint, CV death, MI stroke, or heart failure hospitalization. Both of these were reduced significantly. This update was looking at another pre-specified outcome, which was new onset atrial fibrillation. And here you can see the occurrence of new onset atrial fibrillation in this population. So placebo shown in black and finerenone shown in blue. And you can see that there was a 29% relative risk reduction that was statistically significant in new onset atrial fibrillation compared to placebo. One of the reasons that this caught my eye was because we had seen something similar to this with eplerenone in the Emphasis heart failure trial when we did that about a decade ago. In fact, again, we had new onset atrial fibrillation as an exploratory outcome, although it wasn't adjudicated like it was in the Fidelio trial. But again, you can see here a statistically significant reduction. So I think these drugs, MRAs, do reduce the risk of developing atrial fibrillation, and it's another very good reason to try and use these drugs wherever possible in patients who have an indication for them. So sticking with the theme of atrial fibrillation and the consequences of that, one of the real highlights of the ACC 21, I would say one of the most talked about trials, was this left atrial appendage occlusion study. Again, this was a Canadian study, actually, strangely enough, many years ago, when I chaired a funding committee for the Canadian government. This was one of the trials that my committee recommended should be funded because we thought it was such an innovative idea. So it was wonderful to see, after several years, this trial finally presenting. So this was a study looking at whether or not it was worth either amputating or closing the left atrial appendage in patients undergoing cardiac surgery for other reasons. The idea, of course, being that this might reduce the source of embolism, might reduce the risk of stroke and systemic embolism. So in this trial, patients undergoing surgery were randomized to have left atrial appendage occlusion or excision. They were followed up every 6 months, as you can see here, for occurrence stroke. They were all receiving anticoagulation, and the study was stopped early for benefit after a mean follow-up of almost 4 years. Here are the procedures that patients underwent. As you can see here, the majority of them were undergoing surgery for valve disease, although some, a fifth, were just having isolated coronary artery bypass grafting. As I said, most patients were getting anticoagulation because they had an indication for anticoagulation. So this was really looking at the benefits of left atrial appendage occlusion or excision in addition to anticoagulation. And this is the result. This is the primary endpoint, stroke or systemic embolism. As you can see here, this was reduced by 33% in the patients who had left atrial appendix occlusion or excision compared to those who did not. And this really was, in my view, a very, very important finding. I haven't had time to show you, but to do this, to either excise or to close the left atrial appendage adds literally 2 or 3 minutes to the surgical procedure, but has clearly a large and very clinically important benefit. And I think this should now become standard of care. So what else did we see at this Congress? Well, as you know, I'm interested in SGLT2 inhibitors and their role in the treatment of heart failure, prevention of heart failure, the treatment of chronic kidney disease, as well as type 2 diabetes. And we saw some follow-up information about these drugs in heart failure. And we saw, I'll show you in a moment, a very interesting new trial looking at an SGLT2 inhibitor in patients with COVID-19. So Deepak Bhatt from the Brigham and Women's Hospital in Boston presented some follow-up data from 2 large trials that were carried out using sotagliflozin, which is actually both an SGLT1 and 2 inhibitor, though it's predominantly an SGLT2 inhibitor. These 2 trials were Soloist worsening heart failure, which was a trial in patients admitted to hospital with worsening heart failure. These patients could either have HFrEF or HFpEF. And then there was a sister trial in patients with chronic kidney disease. As you can see here, a very large trial. And these patients also were followed up for heart failure, hospitalization, and cardiovascular death. So Deepak presented the data on the 739 patients in these 2 trials who had heart failure with preserved ejection fraction. So we know that these drugs work in patients with HFrEF, reduced ejection fraction. Here's the largest data set that we have to date in patients with HFpEF. So this is these are from the 2 trials, and you can see, looking at this primary composite endpoint, this is looking at total events. So this is first and recurrent heart failure visits and heart failure hospitalization plus cardiovascular death, a 37% relative risk reduction, highly statistically significant, a very large absolute risk reduction, very early onset of benefits. So very interesting findings. And then Deepak also presented this very nice figure, and this is the way that we increasingly present data where we look at the effect of treatment according to a continuous variable. So here is ejection fraction along the x-axis, so from 20% to 80%. The y-axis shows you the event rate per 100 person years of follow-up. So of course, as you can see here, if you look at the red line, this shows you the event rates according to ejection fraction in patients in the placebo group. So of course, patients with the lowest ejection fraction have the highest event rate. The shaded area around the line is the 95% confidence interval. And I want you to look at the blue line. This is the sotagliflozin group. And again, the shaded area is the 95% confidence interval. And what you can see here is that throughout the whole range of ejection fraction, the event rate is lower in patients randomized to sotagliflozin than in patients randomized to placebo. Now, the 95% confidence intervals overlap a little bit here at the very low end of the ejection fraction range, and that's because there were not so many patients. The number of patients with a very low ejection fraction was quite small, and the same is true at the other end of the ejection fraction range. The confidence intervals overlap here, and that's because there were not many patients with these very high ejection fractions. But over most of the ejection fraction range, you can see here that these two groups do not overlap. In other words, sotagliflozin was really beneficial, statistically significantly better than placebo across most of the ejection fraction range here, HFrEF, heart failure with mid-range ejection fraction, and HFpEF. So I think this gives us a lot of hope for these two well-dedicated, large HFpEF trials with SGLT2 inhibitors. This one is almost 6,000 patients, delivers over 6,200 patients. This trial will report at the European Society of Cardiology Congress in just a few months' time. So we'll get definitive evidence in the next few months, but I would have to say it's looking very hopeful as a result of those data. Now, this was one of the most intriguing trials I thought presented at ACC 2019. It was appropriately named DARE 19 because who would have dared to give an SGLT2 inhibitor to patients admitted to hospital with COVID-19? But Mikhail Kosovorod and colleagues did do that. So here you can see the patients they studied. So these were patients who'd been admitted to hospital acutely with COVID-19. They had to have, most of them had a confirmed SARS-CoV-2 test. They had to need oxygen, and they had some other risk factors as well. And here is the primary composite outcome. It was not reduced statistically significantly by dapagliflozin, partly because the event rate fell dramatically over the course of enrollment in this trial. When this trial started, there was about a 25% mortality amongst patients admitted to hospital in the US with COVID-19. By the end of enrollment, the mortality had dropped to about 5%. So this trial was a bit of a victim of the changing risk of patients hospitalized with COVID-19. But nevertheless, you can see that all of these point estimates favor dapagliflozin over placebo. So whatever organ you look at in terms of worsening function, the lungs, the heart, or the kidney, or whether you look at mortality, all of these endpoints were in all of these point estimates, were in favor of dapagliflozin. But why this trial was, I think, very intriguing was it was a real canary in the coal mine test again of this whole question of ketoacidosis. We're constantly warned about the dangers of ketoacidosis with SGLT2 inhibitors, patients admitted to hospital who are acutely unwell. And of course, here is a group of very sick patients exposed to an SGLT2 inhibitor or not. And as you can see here, there were only 2 cases of ketoacidosis in the whole trial. And in fact, all the other adverse events were, if anything, less frequent with dapagliflozin than with placebo. So if nothing else, this trial was reassuring for our use of these drugs in patients with heart failure and chronic kidney disease, even if they've been hospitalized. So sticking with COVID-19, there's been, as you know, a lot of interest in the role of thrombosis and thromboembolism in these patients. The idea that COVID-19 causes an endotheliolitis and risk of thrombosis, particularly in the pulmonary circulation. I think we've all seen that in our patients. So this was a trial randomizing patients admitted to hospital with COVID-19 with elevated D-dimer to sort of aggressive therapeutic anticoagulation versus the standard prophylactic anticoagulation. So, for example, low-dose enoxaparin compared to, in unstable patients, therapeutic dose enoxaparin or oral rivaroxaban initially, and then patients after they stabilize going on to oral rivaroxaban. This trial had used what's called a win ratio endpoint, but basically this was a hierarchical endpoint where patients were assessed first for mortality, then for their length of stay in hospital, then for the length of oxygen therapy that they needed. And basically, the therapeutic approach, the more aggressive anticoagulant approach, did not show any benefit. In fact, if anything, it actually looked a little bit worse than prophylactic anticoagulation. Here are some other endpoints. Here's a composite of thromboembolic outcomes. This maybe was a little bit more favorable in the aggressive anticoagulation group than the prophylactic anticoagulation group, but there was no statistically significant difference. All-cause mortality trended in the wrong direction. It wasn't significant, but it certainly didn't look favorable. And as you might expect, there was a statistically significant, more than threefold increase in important bleeding. So this trial really did not show a benefit of aggressive anticoagulation in patients with COVID-19 who were D-dimer positive, as so many of them are. Although we'll have to say this is a rather small trial, relatively short follow-up. It is possible that a bigger study might show something different, but this, to my mind, is not particularly encouraging. Now, there are many other trials like this. Maybe we'll get a clear answer as time goes by. So really, I don't think this encourages us to routinely, aggressively anticoagulate patients. Sticking with anticoagulation, another question I think we've all had is whether or not anticoagulation is valuable in patients undergoing transcatheter aortic valve replacement. So this is a reasonably large trial that looked at routine use of apixaban compared to standard care in patients undergoing TAVR. And here you can see, here, first of all, you can see the patient characteristics. Over here, you can see the treatment that they received and the type of procedure the patients underwent. So as you can see here, standard of care in the majority of patients involved either single or generally dual antiplatelet therapy. So this wasn't a comparison of apixaban versus nothing. This was a comparison of apixaban versus generally antiplatelet therapy, but sometimes in a fifth of patients, anticoagulant therapy. So this was a sort of anticoagulation for everybody versus anticoagulation in some people and antiplatelet therapy in most of the others. And here is the primary endpoint, which was time to death, stroke, myocardial infarction, systemic embolization, DVT or pulmonary embolism, and major bleeding. So a very broad composite endpoint, and a sort of net clinical benefit endpoint, incorporating both the risks of anticoagulation and the potential benefits of anticoagulation. And as you can see here, the hazard ratio was above 1, again, not statistically significant, but certainly not favoring apixaban compared to standard therapy. And then to finish my comments on anticoagulation, antiplatelet therapy, I'm going to show you the adaptable study. This was probably the second of the three most talked about trials at the American College of Cardiology. I don't think it gave us a very important clinical message, but it did suggest a very important way forward in doing clinical trials. So this was a trial asking the question of whether or not low-dose aspirin was effective as larger doses of aspirin. As you know, the Americans often still use 325 milligrams of aspirin, whereas in Europe, we use 75 milligrams or less. I'm not sure what you use in India. And this was a trial really to try and compare those two aspirin dosing regimens. So these are the patients who were included. The idea was to get a large population at risk of events so that the trial had enough power to differentiate reliably between two active treatment groups. And the important thing about this trial, not really the clinical question, I think, the important thing about this trial was the way it was done. This trial really recruited patient volunteers from the population at large by reaching out through social media and other channels to people who might be willing to take part in the trial. The endpoints were ascertained through examination of electronic records, through patient reports, and through insurance claim data. So this was a very high-tech but low-cost trial, and I think it gave a very clear answer. So here you can see there were 15,000 patients randomized. There were a large number of events. About 14% of patients had an event, and you can see that there was absolutely no difference between the two treatment groups in terms of vascular events, although interestingly, there was also no difference between the two treatment groups in terms of bleeding events either. So we use 75 milligrams in the UK. I think we'll continue to do that. There's certainly no reason to use 325 milligrams, and I presume those people in the US who still are using larger doses of aspirin will probably now change to using lower doses. But as I say, more about how you can conduct a trial very inexpensively, a large-scale trial using modern methods of tracking events through electronic records and other means, rather than the elaborate and expensive traditional clinical trial approach. So to finish up with, I want to mention one or two things about the treatment and prevention of heart failure. So one of the clinical trial updates was one that we presented on the Galactic HF trial. This was the most recent of the large heart failure trials to show a benefit of a new type of therapy. This is a drug, omecamtiv mecarbil, that improves left ventricular systolic performance. It acts on actin-myosin binding. So it's a small molecule that acts on actin-myosin binding to slightly prolong the duration of that binding, to slightly prolong the duration of systole, and in that way improves left ventricular systolic function. It's not a classical inotrope, doesn't cause all the problems related to classical inotropic drugs. And in the Galactic HF trial, we showed in November that there was a small but significant reduction in the risk of cardiovascular death or heart failure hospitalization, an 8% relative risk reduction. We were really quite disappointed by this, but we've looked into this further. We showed in November that there was a significant interaction between baseline ejection fraction and the effects of this drug, whereby omecamtiv mecarbil seemed to be more beneficial in patients who had an ejection fraction at or below the median value of 28%. So John Teerlink presented more information about this at the ACC. So in a very similar figure to what I showed before for sotagliflozin, here you can see the event rates in the placebo group and in the omecamtiv mecarbil group according to baseline ejection fraction. And of course, as expected, the event rate is much higher in patients with a low ejection fraction, but you can also see that these two curves separate as ejection fraction decreases, and the event rate becomes substantially less in the normal group compared to the placebo group in those individuals with the lowest ejection fraction. So in other words, as you can see here, the treatment effect, the difference between these two groups becomes larger as the ejection fraction falls. And this is just another way of showing that. This is a hazard ratio of 1, so that's unity. This is a continuous hazard ratio. These are the 95% confidence intervals, the dotted lines. You can see that the hazard ratio here is consistently below 1 in patients with an ejection fraction, certainly below 25%. So this drug really does seem to be working as we might expect in patients with the most impaired left ventricular systolic function. And in fact, in those patients, the number needed to treat is actually quite small. And we do think, having looked at this in a lot more detail, that this drug may, in fact, still have an important role to play in our sickest patients with heart failure and reduced ejection fraction, especially as this treatment has no effect on blood pressure, no effect on kidney function, can be given to really sick patients. And in fact, it is in those patients that it maybe has the greatest benefit. So watch this space. We expect more news about this drug over the next few months. And I just mentioned the mirror image, the almost direct opposite of this whole development, which is another drug that has been developed to treat hypertrophic cardiomyopathy. This drug targets exactly the same mechanism, but in the opposite direction. So instead of enhancing actin and myosin binding, this drug, mavacamten, inhibits actin myosin binding. And this drug has been specifically developed to do that in patients with hypertrophic cardiomyopathy. In other words, to try and reduce the hypercontractility and impaired relaxation that characterizes this condition. So it's a really neat story that these two drugs, these two completely different molecules, have been specifically chemically designed to target this physiological mechanism, but to have the opposite effects. And this drug has already been shown to improve functional capacity in patients with hypertrophic cardiomyopathy. And in this clinical trial update, there was a presentation of its effects on quality of life in patients with hypertrophic cardiomyopathy. And here you see the mean change in Kansas City Cardiomyopathy Questionnaire overall summary score. So an improvement means an improvement in quality of life. And here you can see there was a very clear improvement in quality of life. In fact, there was a 9-point improvement in quality of life, which is a very large change. In our heart failure with reduced ejection fraction studies, the average improvement in quality of life is usually at best 3 points. This is a 9-point improvement in a double-blind placebo-controlled randomized trial. So a very interesting new type of therapy for patients with hypertrophic cardiomyopathy, targeting the sarcomere, targeting actin myosin binding. And then I'll finish with a trial that was presented by my good friend Mark Pfeffer from the Brigham and Women's Hospital. And this was a trial that we conducted in patients with acute myocardial infarction. This was a trial that really targeted the population that we had studied in the era of ACE inhibitors, and then more recently with valsartan, patients at high risk of death and developing heart failure as a result of suffering significant left ventricular damage at the time of acute myocardial infarction. We know that these patients are at high risk, and we know that ACE inhibitors, and as a result of the Valiant trial, valsartan, can reduce the risk of death and reduce the risk of developing heart failure in these patients. So we wanted to compare sacubitril valsartan to an ACE inhibitor in high-risk patients after myocardial infarction. As you can see here, India contributed a lot of patients, more than 300 patients, to the Paradise MI trial. So these are the patients who enrolled. As you can see, most of them have STEMI. Of them, as you would expect today, had coronary reperfusion therapy, generally primary PCI. The mean ejection fraction at enrollment was about 36%, and these were very well treated patients, almost all of them on a beta blocker and dual antiplatelet therapy, and a substantial proportion also on a mineralocorticoid receptor antagonist. And before they were randomized, most of them were an ACE inhibitor or ARB, randomized to sacubitril valsartan or to ramipril, one of the proven ACE inhibitors in this patient population. Unfortunately, as you can see here, we did not see a significant reduction in the primary composite endpoint, which was time to first occurrence of cardiovascular death, first heart failure hospitalization, or first presentation ambulatory care setting with incident heart failure. So because this was a heart failure prevention study, we also had, as part of this composite outcome, incident heart failure presenting in the community. All of these events were adjudicated. Here is a breakdown of some of these events and some of the secondary outcomes. So you can see here cardiovascular heart failure hospitalization, or those outpatient heart failure events. And here you can see a pre-specified, again, secondary outcome looking at cardiovascular death and total hospital admissions for heart failure. So not just first admissions, but second, third, or additional admissions to hospital. In fact, as you can see here, this was a nominally statistically significant benefit. So everything looked in the right direction, but other than this secondary outcome, unfortunately, was not statistically significant. Now, here's the detail of these first and recurrent events. So looking at total events, and if we focus on failure hospitalizations, outpatient worsening events, and cardiovascular death, you can see that these events were reduced significantly. And in fact, if we looked at investigator-reported events, again, there was a significant reduction in events. And what happened in this trial was that many of these events, outpatient presentations with incident heart failure, so first heart failure event presenting in the community. Most of these events were not confirmed by adjudication, primarily because of missing clinical documentation. We had a very rigorous adjudication process. We had to have written documentation that patients presented with at least one symptom and intensive heart failure. We had to have documentation that patients received new treatment for heart failure, and often that was not available, particularly because this trial unfortunately was affected by the COVID-19 pandemic, and the majority of these events were rejected by the Endpoint Adjudication Committee because they couldn't be confirmed. And as you can see here, they were particularly reduced by sacubitril, valsartan, and ramipril. So unfortunately, I think this trial was probably a bit of a victim of the COVID-19 pandemic. And here you can see the total events. Here you can see the investigator reported events. Obviously, we had more numbers for these, and with more numbers, we had more statistical power. And with more statistical power, we were able to show a nominally statistically significant reduction in events. But these, of course, are exploratory endpoints. They're not the primary endpoint. This trial did not meet its primary endpoint. But what this trial did do was demonstrate the dramatic improvement we've seen over the past few decades in risk of death, in other words, dramatic improvement in survival in patients suffering myocardial infarction. Remember, these are all patients with large myocardial infarctions, people who had pulmonary congestion complicating their myocardial infarction, people who had left ventricular systolic dysfunction. And you can see over the decades the striking reduction in mortality. So I suppose that's the good news from this trial. It's confirmed the success we've had in treating myocardial infarction. So with that, I'll stop. That was my summary of what I thought were the interesting trials at American College of Cardiology, although I appreciate that you may have seen other things that you found more interesting.
Thank you, Dr. McMurray. I think you picked up, I guess, trials which would interest most of the cardiologists. And from that angle, though I am a hardcore interventionist, I thought the last trial discussion, the Paradise MI, where ARNI was not found very effective in AMI. ARNI is one of our main drugs for heart failure these days, but for acute cases, probably not very different. However, in all the slides which you showed, it was better than ramipril. Maybe not statistically better, but the graphs show that it showed more.
Yes, you're absolutely right. I agree with you completely. I mean, I don't want to, I need to tread a very careful line here. I mean, my own view of these data is that they clearly show a benefit, but there were problems with the power that the trial had, because many of the most responsive events to sacubitril valsartan, many of those events were excluded from the primary analysis because they couldn't be confirmed by adjudication. But if you increase the power of the study, either by looking not just at first hospital admissions, but looking at recurrent admissions, or if you just take what the investigators reported, you can see that clearly there is a benefit. I suppose the other way to look at it is sort of to do almost exactly what you said, which is to say that here In the first part of these cumulative incidence curves, this is the acute MI patient. Out here, this becomes the paradigm heart failure patient. So in this very early phase, there's very little effect. But as the patient becomes more chronic, then you do see that difference that we know about from paradigm heart failure. So I suppose that would be one way to look at this. But again, I don't want to over exaggerate it, but I agree with you. I do not think there was no effect. I just think it was smaller, and we had problems with the essentially the statistics, the power of the trial.
So as we start ramipril for all myocardial infarction on day 1 or day 2, where would you think we can put this combination for treating heart failure, say major heart failures like anterior wall MI? They are not in frank heart failure. But
I would have to say that, I mean, given that this is, at least in most countries, a much, much more expensive drug, then I don't think that we're in a position to say that we should start this after myocardial infarction. I mean, if the patient, I can't remember exactly what we did in Paradigm because it's now 6 years old, but I think we excluded patients who were within 3 months of myocardial infarction when we enrolled them in Paradigm. So I think it's when does a Paradise MI patient become a Paradigm heart failure patient? And I would say it's when your patient develops the clinical syndrome of heart failure. Remember, most of these patients didn't have any evidence of heart failure. In fact, we excluded patients who we thought had persistent heart failure. Some of these patients had transient pulmonary congestion, complicating their acute MI, but we didn't include patients. We deliberately excluded patients who had persistent heart failure early after myocardial infarction. So I think it's when your patient develops persistent heart failure that they then become a candidate for sacubitril valsartan. But I wouldn't, on the basis of this, routinely start all MI patients on sacubitril valsartan. I just don't think we have the evidence to do that.
Dr. Jessimohan and Dr. Samitra, you have a question?
John, I have a question. In ACC 2019, Furtado presented data from the DECLARE subgroup analysis of DECLARE TIMI 58, and he showed that although HFrEF patients benefited from dapagliflozin, non-HFrEF, which obviously I would interpret as a HFpEF, did not benefit. So how do I take that data compared to SOLOIST plus CORED data? I know the numbers are small in both, and you want us to wait for Emperor Preserved and deliver to come to some kind of conclusion. But I want your views, I want your comment on that. Why two different ways of looking at non-HFrEF, if not HFpEF?
Okay, well, great question. You've got a, oh, there's an echo, and you've got a very good memory. But I think there's a huge difference. So in the DECLARE TIMI 58 trial, there was a much smaller number of patients and a tiny number of events. I mean, I think it was around 20 or 30 events. So there's really no comparison, because although SOLOIST worsening heart failure still only had 759, I think it was, patients with HFpEF, don't forget this was an acutely hospitalized population. Patients were randomized either in hospital or within 72 hours of discharge from hospital. So of course, they were a very high event rate group. So I think it was something astonishing, like about 50 events per 100 person years of follow-up or something within just 9 months of being enrolled in that trial. So although the number of patients enrolled was still modest, the number of events was, I don't know the exact figure, but I would reckon probably of the order of 10-fold the number of events in declared TIMI 58. So if you had to say which of those two trials was likely to give you the best estimate of the effect of an SGLT2 inhibitor in patients with HFpEF, it's definitely soloist worsening heart failure by a million miles, no question. And then I think the other interesting thing is that, of course, one of the as you know, initial actions of SGLT2 inhibitors is they have a modest, short-lived diuretic effect, and that might be especially relevant in patients like those who were enrolled in soloist worsening heart failure, where almost by definition, they were admitted to hospital with congestion, and probably even when they left hospital, still had probably incompletely treated congestion. So again, they may have been a group of patients who were most likely to demonstrate the benefit of this type of treatment. So so that would be my explanation for the apparent discrepancy between the two trials.
I quickly want to comment on ACTION trial, actually, which you presented, therapeutic versus prophylactic anticoagulation.
Yeah,
actually, the observational data which Valentine Fuster published last year in May, that 4,394 patients also had similar data, that between prophylactic anticoagulation and therapeutic anticoagulation, there is no difference. And a randomized data came from Iran, actually, I think, called Inspiration,
yes,
which had exactly similar finding as ACTION has got. So probably it appears that therapeutic anticoagulation probably is dead as far as COVID treatment is concerned, barring maybe selected patients where it may be required.
Yeah, I think there's still some other trials underway. I know about the Iranian trial. In fact, I think it's probably in JAMA, and they presented, it was a 2x2 vectorial design, and they also presented a statin versus placebo comparison that didn't show anything either. But I tend to agree with you. It looks, again, it probably depends a little bit on the patients who are enrolled, but it looks like for that general population hospitalized with elevated D-dimer, aggressive anticoagulation maybe does more harm than good. But, you know, those patients who are in the intensive care unit who are really sick, I mean, we've been seeing, or not recently, but we did see a lot of major pulmonary emboli. So, you know, you have to have, I think, a very, very low threshold for looking for and detecting and treating pulmonary embolization, but in the patient who maybe only requires suppuration, who gets a bit of dexamethasone, who doesn't require ventilation, then I think you're probably right. I think we're maybe doing more harm than good to use aggressive anticoagulation.
Dr. John, based on this DARE-19 study, there was a mortality reduction from 25 down to 5%. So where will we use DAPA in COVID-19 cases? You wait for echo to show some abnormality and then use DAPA, or we can give it straight away?
Oh, I would not use an SGLT2 in COVID-19 because DARE-19 wasn't a positive trial. I mean, there were 54 deaths in the placebo group and 41 deaths in the dapagliflozin group. The hazard ratio was 0.77. The 95% confidence intervals went from 0.52 to 1.16. So we can't say that there was a reduction in mortality. Now, I have to say the trial overall was surprisingly tantalizing, I think might be the best word, at least in my opinion. I mean, when I first heard about this trial, I thought it's crazy. But actually, Mikhail Konnect, I think, had a brilliant idea, and everything about every endpoint trended in the right direction. And even respiratory failure was less common in the DAPA-treated group than the placebo-treated group. And I've actually heard of some more recent data now suggesting that the dapagliflozin protects the lungs in sepsis and in other conditions. And I don't think it's DAPA, I think it's SGLT2 inhibitors in general. So yes, this is really, I wish they'd done a bigger trial. I don't know if there'll ever be another trial, but I wouldn't routinely give it. But on the other hand, I think if my patient was admitted to hospital with my COVID-19, if they were admitted to hospital with worse heart failure, I certainly wouldn't stop dapagliflozin, but I don't think I would start it.
Dr. Soumitra, you have anything?
Yeah, one question regarding Paradise and another relatively unrelated viewpoint about ACC presentation. One, I mean, Paradise was not a negative trial. Maybe you can say it was non-inferior to Ramipril. And as in some ways exploratory endpoints, it was superior. So what is your gut feeling? What kind of recommendation is it going to take in post-MI patients in guidelines? At par with ACE inhibitors or somewhere down the line, class 1 recommendation or something different?
Well, that's the point, but I don't see it being used in that way. So yes, you're absolutely correct. We could say that this showed non-inferiority. I mean, the upper 95% confidence interval for the primary endpoint was 1.04, so that would meet anybody's criteria for non-inferiority. But what non-inferiority means is no better than. And so if you strictly interpret the adjudicated pre-specified primary endpoint, the best you can say is sacubitril valsartan was no better than Ramipril. And why would I use sacubitril valsartan then in preference to Ramipril? Because it's more expensive. I didn't have time to show you all the data. I mean, it was remarkably well tolerated. I would say that actually probably the thing I took away most from that trial was that you can give sacubitril valsartan in acutely unwell, hospitalized high-risk patients, and it is well tolerated. There was no difference from Ramipril. And I suppose you could say back to me, well, the Pioneer heart failure trial showed that was a rather small trial. It was only 900 odd patients. This was obviously a much bigger study. So I suppose it's confirmation that you can give sacubitril valsartan in the acute setting. It will be well tolerated. And to me, that might be the most important take-home message, because there's still, I think, a bit of concern about giving sacubitril valsartan to hospitalized patients with heart failure. Well, here is a very similar population. And here is a very large data set showing that you can completely safely give sacubitril valsartan to sick patients. So I think that's a valuable lesson from this trial. I don't think probably the guides are going to give a recommendation for sacubitril valsartan, and I don't think people are going to use it because it's more expensive. And if it's not better, then why would you use a more expensive alternative drug? I think that would be the strict way to look at these data. Now, is that what I think this trial really showed? No, I think there probably was some benefit, but there's a difference between what I think, and I'm biased, and what the trial, strictly speaking, demonstrated. And the strict interpretation of this trial is that it was neutral for the primary endpoint. There was no benefit, but you are right. Technically, you could claim non-inferiority.
My second comment is, I mean, beyond your otherwise brilliant compendium of highlights, there was a lot of news about clopidogrel. So it was a kind of resurgence of clopidogrel in ACC 2021. I mean, as a single antiplatelet in chronic coronary syndromes and as a de-escalation therapy versus ticagrelor, and even in the extended arm beyond 1 year versus ticagrelor, there are a lot of positive news. Again, non-inferiority and some kind of superiority over aspirin in the chronic situation. So comments from you and any of the esteemed panelists.
Yeah, I'm sorry for not talking about that. I did see a very interesting trial from Korea, but I had a limited amount of time. And as you know, I'm an antiplatelet acute coronary syndrome PCI person. That's not my own particular interest, but I did see that and I was interested. And it doesn't surprise me because there was a trial many years ago called the Capri study, which you probably recall, published in the Lancet, that again came tantalizingly close to that clopidogrel was better than aspirin, but didn't show that in the overall population. But it makes perfect sense, doesn't it? I mean, this is a drug that is not going to irritate your gastric lining. It's not going to directly cause gastric bleeding as aspirin does. And if anything, everything we know about clopidogrel suggests that it is probably a bit more effective as a single antiplatelet drug than aspirin is as a single antiplatelet drug. And I think we would all have used it in that way in the past, except for the fact that at one point it was a very expensive and that borderline benefit in the pre-trial didn't justify it in terms of cost. But of course, today it's very inexpensive. And if I had to take an antiplatelet therapy, I would prefer to be on clopidogrel rather than aspirin.
There are about 1,000+ delegates in this program, and some of them have posted questions in the chat box. You may want to select what you want to answer. Kindly, please.
So, Samitra, we could actually just discuss both these trials quickly. One, of course, let us start with Tello's MI study, which is a de-escalation strategy after 1 month. Aspirin plus ticagrelor for 1 month, and then de-escalate to aspirin plus clopidogrel versus aspirin plus ticagrelor for full 12 months. And the data clearly shows that the bleeding is about 50% less, about a little less than 50%, about 40% less. Bar 3 to 5 bleeding is less if you de-escalate, and the ischemic events are same. Now, it is a fairly large study, actually, when you look at 5,000 odd patients and meticulously planned. This is the kind of thing we have been doing for quite some time, de-escalating after a month, 2 months, 3 months. Actually, a similar study like this was presented in EuroPCR in 2018 by a Swiss group. It was called Topical. Topical was a study of 660 odd patients. They did exactly the same, and they showed that the bleeding was less by 50%, and number needed to treat actually to get a benefit was something like 8-9, which was phenomenal. And the ischemic event, actually, Bob Harrington has been saying for a long time that the ischemic risk is time dependent. After 1 month, it tapers off. While the bleeding risk is non-time dependent, it remains constant throughout life. So it makes sense to give intensive therapy for first 1 month and then de-escalate. With regard to host exam study, and Dr. John McRae rightly said Capri almost came closer to showing superiority, and host exam shows you that after 6 to 18 months of DAPT, you can use clopidogrel is superior now here with regard to bleeding as well as with regard to ischemic event. 28% superiority for ischemic events and nearly 50%, not nearly 35% reduction in bleeding. seems we would change to clopidogrel more often after we have to give a single entry platelet therapy.
Yeah, Dr. John, I still remember the BMJ editorial after Capri, which said that had clopidogrel been less expensive, it would automatically be the first choice as a SAPT or aspirin. And days have come where it is relatively inexpensive. So, I mean, I hardly find any reason why we should stick to aspirin as our first choice for SAPT and not switch over to clopidogrel.
You know, John's colleague, Dr. John Cleland, has been actually a very vocal person against aspirin for a long, long time. And I think his editorials, his comments have been very pithy. And and those have been very hurtful to aspirin evangelists, because he believes finally the treatment of ACS would be aspirin free. The treatment of coronary artery disease will be aspirin free.
Yes, I hope you can see it on my screen. So yeah, this was interesting. I mean, I suppose the only question was, I believe this was just in Korea. I don't know whether South Korea is the same as everywhere, different from everywhere else, but I don't find the results surprising for the reasons that we lost. So I agree, very interesting study. I have no question which I would want to be on.
Shirish?
You know, Dr. John, there are very few drugs for heart failure with preserved ejection fraction. And so where would you put the two new things trials you discussed, Solicit and SCORED? So are they giving us any lead to how to treat diastolic heart failure?
So good question. So, I mean, I said I think SCORED is tantalizing because it isn't definitive. We can't claim that in a sort of pooled analysis from a KD in a heart failure trial and a modest number of patients, really claim that that's enough evidence to change practice. But as I also pointed out, we've got these two huge trials, like 6,000 patients each, that will be reporting very shortly, dedicated HFpEF trials, robust, adequately powered. We will get a definitive answer. And my hope is that it will be a positive answer. I truthfully don't know, but I think everything is pointing in the right direction. And if that happens, it's going to be an enormous breakthrough. I mean, a really, really huge breakthrough, because as you say, I would say we don't have anything else convincing. You know, the US Food and Drug Administration recently gave approval to sacubitril valsartan to be used at least in some patients with HFpEF on the basis of the Paragon trial, the basis of a subgroup analysis. And I think it's probably true that MRAs are affected as well, but again, we don't have definitive evidence, but we'll get that because again, at the moment, we're doing a very large trial with finerenone in patients with HFpEF. So we're getting there, but we're not there yet. I think this August or September at ESC is going to be the D-Day for HFpEF, because if SGLT2 inhibitors show a clear, large, definitive improvement in outcomes, then everything's changed.
Another notable feature of Soloist was that it was started in hospital or within 3 days of discharge, something we have been empirically doing, but now we have some evidence that it can be started pretty early. So that was another.
Yeah, I don't know what's happening in the UK. I hope you don't have this, but in the UK, the diabetologists, endocrinologists have been going around terrifying the cardiologists by saying, you mustn't start SGLT2 inhibitors in people in hospital because there's a risk of ketoacidosis. fact, they even say that you're meant to stop SGLT2 inhibitors in people admitted to hospital. And I think that's true, obviously, for some patients. If you're sick, if you're vomiting, if you can't eat, if you're on insulin, can't take insulin, yeah, of course, stop your SGLT2 inhibitor. But if you're a heart failure patient and you come into hospital with congestion, then I don't see any reason at all. And as you point out here, did anybody see any other interesting trials at ACC? I mean, I know I picked my selection, but
Dr. John, this atrial fibrillation, the first study you presented, rhythm control better than rate control. Now, this will hold true for all AFibs, or many AFibs can be on rate control. I mean, that
so I'm just letting you know.
Practice.
No, I have announced. It's the word in the announcement also. I have announced.
Mr. Raghu, there is some
sorry,
disturbance. Yeah, Dr. John.
Well, so the problem is that the RAFT AF trial did not show a clearly significant benefit, at least for the primary endpoint. So it's the usual story. It was tantalizing, but not significant. And I think that was, again, partly because it was too small, because it had recruitment problems. So it's not definitive. Now, to be fair, I think if you put the heart failure subgroup from, I've forgotten I'm blocking on the name of the big AF trial.
Cabana AF. Cabana. Cabana AF.
Cabana, yes, yeah. If you put all of these together, then yes, I mean, collectively they do suggest that there's some good from AF ablation, but it's such a pity that they couldn't do a single large definitive trial to give us all clear and convincing evidence. We just don't have that yet. If you ask me, do I think on balance the totality of the evidence suggests that a good strategy, then the answer is yes. In what patients? I think that's a more difficult question. I mean, undoubtedly, I think it's more appropriate in patients who've got paroxysmal atrial fibrillation, or in patients who've got recently developed persistent atrial fibrillation. I think once you've got a large remodeled heart with very large atria and atrial fibrillation for a long time, I think it becomes technically, at least this is what we're finding, technically more demanding to successfully ablate those patients to maintain sinus rhythm. And they're also the ones who are more often patients who get complications such as, atrial perforation and so on. So I would say in where I work, and we tend to be more conservative here, but where I work, if you've got long-standing atrial fibrillation, if you're a patient who's been in my clinic for 5 years with heart failure in atrial fibrillation, you're not going to get referred for AF ablation. But if you're somebody who's got paroxysmal atrial fibrillation and it's relevant, then that is the sort of patient that we would think about referring for AF ablation.
Yeah, but it's interesting, John.
What's happening in India?
Much less ablation for heart failure, but a lot for paroxysmal atrial fibrillation. But this question which you have raised is very interesting, because a FORM trial was negative, Castle AF trial was negative, and now your RATE AF, which is largely negative, let's call it, but the Cabana AF was positive trial. So in a situation where some trials are positive and some are negative, it is difficult to give recommendation to the patient.
Well, actually, Cabana wasn't positive by an intention to treat analysis.
Yes.
So the primary analysis of Cabana wasn't positive. Castle AF technically was positive by intention to treat analysis, but there were lots of issues about it was small, there were imbalances between the two treatment groups. There was a blanking period, which is always a very difficult thing to understand, this period where episodes of recurrent atrial fibrillation don't count. So none of the trials are clear cuts and definitive, but if you put them together, then yes, they do suggest a benefit. But you're right. I mean, that's a difficulty we always have if you've got trials giving inconsistent results. I think it does create some uncertainty in the clinical community, and I think there's a lack of confidence in the clinical community when you don't find consistent results. You know, if you think about something like the SGLT2 inhibitors, we've seen so many positive trials. I don't think there's any argument about those drugs, but when you have trials with catheter ablation, all of which have got borderline benefits or subgroup benefits or secondary endpoint benefits, becomes, I think, a lot harder to have the same level of confidence. But I think, you know, it's the totality of evidence probably suggests there's something good happening there. And my worry is that we'll probably not get a definitive heart failure trial again, because I just don't think there's a will to do another trial.
There is a question in the chat box on mavacamten. I mean, we haven't talked about it. Can it reduce sudden cardiac death is the question from one member of the audience. I mean, do we have an answer to that? I don't think.
No, we absolutely don't. It's a very, very hard answer to get. I mean, doing any trial in patients with hypertrophic cardiomyopathy is a real challenge, and it's actually only, I would say, recently that there have been even 2 or 3 modest-sized trials in this disease, because although everybody says it's quite common, when you go and look for it, it's actually quite hard to find, and they're just, it's not like heart failure, it's not like atrial fibrillation. There are really no networks, international networks of centers that can enroll patients. We have another trial. In fact, when I was working in Boston 10 years ago, believe it or not, we designed a trial in hypertrophic cardiomyopathy, which is just recently completed, and it's again a very small trial. It's just under 200 patients in size, and it's taken a very long time to do that study. It's just a very, very hard disease to study, and I would be very surprised if it would ever be possible to do a large outcome trial like we're so used to doing in patients with heart failure and preserved or heart failure and reduced ejection fraction, unfortunately.
Dr. Altaf, we have any questions, or we are coming close to
the questions are all the delegates' questions which were asked. So if we have come to the end of this discussion,
yes.
sir, is it I presume that?
Yes,
if anything you want to have discussion around, it's fine. Otherwise, sir, on behalf of Acumentis and my division Noveltis, we thank all our esteemed faculties for participating in this ACC Konnect program. My sincere gratitude to Dr. M.S. Raman, Dr. J.C. Mohan, Dr. Soumitra Kumar, and of course, Dr. John McMurray. My gratitude goes to each and every delegate who has joined this finale of ACC Konnect. I'm indeed glad to mention that we had more than 1,203 to be precise, delegates who joined for this program in India. So I'm very thankful to, once again, to all my, faculties. My sincere thank to also to my senior colleagues, CEO, management team at Acumentis, and all my colleagues from both sales as well as marketing teams who have made this program very, very possible, sir. So from my side and my Acumentis company side, thank you very much. Thank you very much. Thank you very much.
Great effort.
Thank you all.
Bye.
Good to see you. Have a good day again.
Thank you. Thank you so much.
Thanks.
Bye-bye. Bye.
Thank you, Dr. John.
Bye-bye.
Have a good day.
Bye.
Thank you very much, sir. This is on the back end.